Um, Good evening and warm welcome to all of you. On behalf of Heartlines and IACTA West Bengal, it gives me great pleasure to welcome you all to today's mini series of physiology session. We are truly fortunate to gather once again in the spirit of learning, curiosity, and clinical excellence. Our topic today is mechanical ventilation and right heart function. This is a subject that bridges the physiology, anesthesia practice, and the daily decision making in the OR and ICUs. The right ventricle, which is often called a forgotten ventricle, and yet it is incredibly sensitive to changes of preload, afterload, and intrathoracic pressures. In cardiac cases, especially those involving pulmonary hypertension, congenital lesions, valve surgeries, and ECMO, a deep understanding of how the various modes of ventilation affect the right heart performance can be a practice changing concept. So, the ventilation is not just about the numbers on a ventilator screen, it is about the RV geometry, pulmonary vascular resistance, venous returns, septal shift, and the delicate balance between the oxygenation and the hemodynamics. When we understand these interactions clearly, we prevent the RV failure. We can improve the stability during induction, cardiopulmonary bypass weaning, and the postoperative management, ultimately improving the patient outcomes. We are honored and privileged to have with us Dr. Jyotirmay Kirtania, a respected teacher, clinician, and guide whose clarity of thought and depth of understanding make the complex physiology remarkably simple and practical. Sir has always inspired us as a senior to think beyond the protocols and to see the physiology alive in every beat and every breath of our patients. So we sincerely thank you, Jyotin Mahada, for taking your valuable time to be with us in this evening. And to all participants, thank you all for your constant support, constant enthusiasm, and dedication. And let us listen, learn, and always carry our science back into our OR practice from tomorrow morning. With that, I humbly invite Dr. Jyotirmay Kirtania. Sir, please begin the session. Thank you.
Okay. Thank you, Dr. Mona Lisa, for that wonderful introduction and introducing me. So today we are going to dive deep into the understanding of what the mechanical ventilation does to the right heart function and what is the impact of the hidden ventricle and which actually affects the patient outcome. So the overview, I'll be going initially. I'll be going at a high level kind of a description, like a very crude and overview, and then I will go into the like a very much details and the exact things what we assess and what are the things we need to like expect and we need to keep a tab on so that the things goes on track and the patient outcome is as expected. So at the very beginning, I would like to just have a quick recap of the like why at all we have the mechanical ventilation. How game changing was it in the 20th century, and now it is evolved much more, and now we go for ECMO and left ventricular assist device and all those things. So, so the mechanical ventilation was actually a game changer. The surgeries which were previously impossible, like the thoracic surgeries, open abdominal surgeries, they were like a riddled with like a death at every nook and corner. So they drastically reduced the incidence of this thing. But as the nature of human beings, we try to push the limits, and then we hit a ceiling. So how what the mechanical ventilation can do and we can't do. Next, I will recap the quick concept of the different type of hypoxias. Like as we all know, there are like a hypoxia, the commonest type, and we actually measure by your pulse oximetry, PO2 and the SaO2 and also the mixed venous oxygen saturation. Anemic hypoxia is very much evident. You just measure the anemia by the HemoQ or the lab or the ABG, and the your historic hypoxia is very difficult to treat. But what we don't monitor, don't measure, and clinically it is very difficult, but we see all the time, that is your stagnant hypoxia. So that's where the hidden thing comes. So let's move forward. So why at all we need to care about the RV function? Because it's not I would say a powerful person like a left ventricle. Left ventricle is a muscular, mighty muscular, which can overcome any kind of a wide range of a vascular resistance. It can push blood, but RV is just kind of a bechara admi kind of a thing. Or so why? So although it is a less powerful, like a less muscular, the size is also less than the ventricle compared. But why does it become so important? Although it becomes a little bit hidden. Because the RV failure, as you know, the cardiac output, the very basic definition is your stroke volume into heart rate, but the stroke volume is the amount of blood ejected by each ventricle. It's not about just the right or the left, because if one ventricle fails, the other is will definitely fail in terms of just by the your equation of mass. But it becomes much more precarious and much more difficult in sepsis, ARDS, and pulmonary hypertension. I'm talking about like a primary pulmonary hypertension, and also your secondary pulmonary hypertension from your your COPD or your other a vascular diseases, which can cause like a pulmonary hypertension secondary to that. And ordinarily, the traditional view, like a mechanical ventilation, would actually not just supporting the ventilation, it can actually improve oxygenation in patients with ARDS. But we have to know the limits of its capacity and what harm it can do to the right ventricular function, and what is the sweet point, what is the optimum things where we can actually strike a balance between your left ventricular preload, afterload, and also the right ventricular preload and afterload, right? And also keeping in mind the ventricular interdependence. Like if the right ventricle is failing and swells, so what is happening? The just like the skull, it is not exactly like that. So it is the brain is inside like a quite a rigid fascial structure, that's the meninges, and inside the skull, which is more or less rigid. If something increases, something has to compensate and will get pressed. So it's not like a skull, but still it is the pericardium is a tough structure. So it is like a rather unyielding. You cannot just like a bloat it and increase it like that. So it is a quite a tough structure. If something increases in size, like if the right ventricle gets dilated with because of the failure and with lots of fluid, what will happen? The septum would shift. So normally it is crescent shaped. The left ventricle bulges into the right ventricle. But when the right ventricle fails, it bulges into the left ventricle and would actually severely restrict the left ventricular filling, because the left ventricle is now getting very little endostolic volume to fill up. So that's the ventricular interdependence. So as I just told the pericardium, regarding the pericardium, that how the structure, the functional anatomy translates into a pathophysiology. And also the thorax is like a double pressure chamber. So you have the a thoracic cavity which contains the heart and the lungs, and also the lungs, they're expanding and collapsing. The lungs also have a pressurized system. So it's not just the heart the cardiac chamber pressures are important, but the juxta cardiac pressure or the extra cardiac pressures, I would tell. So we have to consider the juxta cardiac pressure. There's a pressure which is exerted on the heart by the adjacent structures, including the lungs, the chest wall, and limited by the pericardium, and the chamber pressures itself, all the four chambers pressures, and any abnormality, so it will be reflected into the ventricular performance. So that's how the anatomy translates into the pathophysiology. So as I've just told, it is a, like I would say, a very ordinary kind of a thing. It's a 1/3 of the mass and volume of the LV under ordinary circumstances, but it can stretch and expand in volume. If you fill with fluid, so the preload increase and its output will also increase. So, but it is there's a very important point. So it's the thing, even if you forget everything, you must remember that the RV is very much sensitive to the afterload. If the afterload increases even a little bit, the RV stroke volume would dramatically drop. This is the thing that we have to just like a belief. Like I just say, we remember profiles of people, of our friends, of people. So you have to like have into your head that this is the very nature of the RV. That's very much like afterload sensitive. Even a slight increase in the pulmonary vascular resistance, so the stroke volume would dramatically like gets decreased. Again, the other thing is that like it has been taught in the very basic physiology. So how does the RV like afterload gets influenced in the in health and in disease during surgery in the ICU? So it's about the PCO2 acidosis and the PO2. So PO2 not directly, but the alveolar, that's a PaO2, that's capital AO2, that's the alveolar partial pressure. So if the alveolar partial pressure is normal or high, the pulmonary vascular resistance would drop. But if there is hypoxia, the pulmonary vascular resistance, it induces pulmonary vasoconstriction and the right ventricular afterload would increase. Again, if you have a hypercarbia, so hypercarbia would again increase the pulmonary vascular resistance and the right ventricular afterload would increase and the right ventricular ejection would decrease. And also acidosis, whether respiratory or metabolic, whatever, acidosis would again cause your pulmonary vasoconstriction, cause the pulmonary vascular resistance to rise. So these three things, these are very fundamental. That's one is the how the RV like afterload is tweaked with this chemical like a signaling. Uh, Even if we forget other things, other chemical mediators and mechanical things, and how exquisitely sensitive the RV is to increase the afterload. So now we will talk about the pressures, the juxtacardiac pressures. So we'll talk about the juxtacardiac pressures. That's the like pleural pressures and the transmural pressures. So, can we have the non-speaker to be muted? Can we have the non-speakers be muted? So now we talk about the like juxtacardiac pressures. So how does they affect? Okay, can we mute the like a non-speaker participants?
আমরা 10 মিনিট দেখবো, উনি যদি 5 মিনিট চোখ খুলে রাখতে পারে তবেই আমরা চোখ এটা করব, তা নয়তো ঠিকঠাক থাকবে আজকে। জলও তাহলে পাবেন না, কিছুই পাবেন না।
Dr. Mona Lisa, can you like mute the non-speaker participants because I think the audience won't be able to hear it.
আমি কোন দিকে দাঁড়িয়ে আছি দেখি আওয়াজ। আমি কিছু দরকার নেই।
And can we have the non-speaker participants muted? Dr. Anushwa, can you please mute yourself? Dr. Anushwa, can you please mute yourself? Dr. Anushwa, can you please mute yourself? Yeah, thank you. So we talk about the transpleural pressures. So normally the pleural pressure is normally negative when we are spontaneously breathing, but when we are with a like a positive pressure ventilation, it becomes positive. So the pericardial pressure that becomes raised. So now again the like a transmural pressure. So that's the intercavitary pressure minus this pleural pressure. So this is actually the filling pressure. So if we see that it's not just about the like a ventricular compliance, how it will be filled, but also the pleural pressure. So in a mechanical ventilation, that is the mechanism, that is the exact mathematical reason why the venous return reduces, because the juxtacardiac pressure is a general stand, there is a pleural pressure that increases. So this it's a very like a intimidating diagram. I'm not like advising to go into like during this lecture. You can see it later on also. I have listed in the references. You can see. So overall, what you need to look. So in the resting state, you can see the what happens to the pleural pressure during spontaneous. So it is actually augmenting. It is actually augmenting the venous return, and it is going to like increase the venous return of the left ventricle, of the right ventricle, and it will increase the pulmonary blood flow. It will increase the left ventricular preload also. So and also as the like your but when it is replaced by your positive pressure ventilation, what happens? So that's the opposite. So the right ventricular preload would get decreased, and since it is connected in series to the left ventricle, so the left ventricular preload will also get decreased because there is less pulmonary blood flow. This is actually beneficial in hypertensive heart failure and when the left ventricular failure. So where you just unload the overloaded left ventricle and you get the benefit. Now this this curve. So try to just understand the thing what we can actually use it, because there is no point in just trying to memorize the curve and try to reproduce without understanding what this is about. So it's a pressure time curve during volume control ventilation. So what is the pressure time curve? So it's a change. It depicts the change in the airway pressure over time. So you can see the variations. One is the peak inspiratory pressure, which is the maximum pressure of the airway during inspiration. Then the plateau pressure. So if you have a like inspiratory pause. So what is inspiratory pause? So now you see, so there is a inspiratory flow. Now you stop the flow, but still there is air which will pressurize the system. So there is no net flow. So there is no net flow, but still the system is pressurized. So here there is a like a plateau pressure. So in all ventilators, on all modern anesthesia workstation, so there is a button called or a knob that is called TINSP, T-INSP, or the P-INSP. So the plateau inspiration. So for like a few milliseconds, like around 5% to 10% of your inspiratory time. So if you put that like a inspiratory pause on and set it to around 5% or 10%, you can actually get the plateau pressure reading on your ventilator. So I would, so it's a common practice. You should practice it in the OT, in the ICU. So the default setting is the ventilator actually shows the mean pressure and the peak airway pressure, which is not much of a use to us. So what we are interested is the driving pressure, which is plateau pressure minus PEEP. So that's the net energy which is delivered to the lungs and which translates into the juxtacardiac pressures. So to measure the plateau pressure, so whenever you start a case or whenever you are going to put the patient on the ventilator, make sure that your screen configuration, your plateau pressure is displayed, and you add around 5% or 10% of your inspiratory pause. So your plateau pressure will automatically be displayed, and you do not need to go for a mechanical maneuver or to just go for an inspiratory hold and then measure and all these things. So it will not be required. It will be automatically be displayed. So your dynamic compliance is your tidal volume divided by the difference between the peak pressure and the peak, where the static compliance means where there is no flow, tidal volume divided by your driving pressure. And the area under the curve by time is your mean airway pressure. So that's the average pressure which your like the airway is subjected during the inspiration. Now So why I went going so much upstream, telling about the ventilation and all these things. So now this plateau pressure under certain circumstances. So we have to imagine some certain preconditions, like there is no severe airway obstruction, like no bronchospasm, no asthma, no severe COPD, no air trapping. Patient is not having like a spontaneous breathing efforts, all mechanical breaths. So under these circumstances, and you have an inspiratory pause also built in. So under these circumstances, your actually your plateau pressure will be equal to your transpulmonary pressure. So this transpulmonary pressure is transmitted to the pericardium, to the both the ventricles. And since the right ventricle is a thin walled, it is more influenced. It is more influenced with this transpulmonary pressure. So I would like a caution against, don't just like assume that your plateau pressure is your what we call the transpulmonary pressure. No, under the certain circumstances, I told, all mechanical breaths, there is no severe airway obstruction. The patient, there is an inspiratory pause built in. So there you can assume that the plateau pressure is equals to the transpulmonary pressure, which is actually transmitted to the ventricle, and which influences the filling of the right ventricle. So that is why when if you have a very high plateau pressure, very high driving pressure, your right ventricular filling would get reduced. So that we have just told. So this is like a pictorial depiction what I have just told. So what happens when you have like a spontaneous breathing? So you have the intraventricular pressure becomes more negative related to the systemic pressure during inspiration. So it actually sucks in blood and augments the right ventricular your like a right ventricular your preload, but it would increase the afterload. Why the afterload would be increased? How does the how does the preload, increased preload becomes like a increased afterload? So if the ventricle is too much loaded, so what happens to the so the isovolumetric contraction phase? So you know 2t by r, the wall stress is the 2t by the radius, right? So if the radius is low, so the 2t, so the 2t by r would be high. If the r is small, the 2t by r will be high. So now if you have if you have a right ventricle which is actually like a your quite loaded, and it is like a pushing into the it is a good contractility and it is pushing into the pulmonary circuit. Or if we consider your the left ventricle, so the more the preload is, that there will be more wall stress. So there will be more wall stress, and so the ventricle has to overcome a much more your increased force to generate the ventricular ejection. So now come to the positive pressure ventilation. So the in the positive pressure ventilation, so what happens? The transpulmonary pressure increases. So so what will happen? It will be have a direct effect on the right ventricular outflow, and since there is a like a pleural pressure also increases, so the direct effect on the right ventricular inflow, so the right ventricular inflow also reduces, and the transpulmonary pressure increases, so it squeezes and squishes the pulmonary vessels. Why? Because the pulmonary vessels are very thin walled, unlike your systemic vessels. So if you have a increased transpulmonary pressure, all the like a thin walled pulmonary vessels will be squished and squashed. So that is going to directly increase the right ventricular afterload. So what happens in net? So there will be increased pulmonary vascular resistance and increased right ventricular afterload. On the other hand, since the pleural pressure increases, so there will be decreased inflow. So the preload also gets decreased. So how this thing works? So the preload has decreased, afterload has increased. So what will happen? The right ventricular output would reduce. So you'll have a reduction in the cardiac output. On the other hand, what is the effect on the left ventricular outflow? So the aortic pressure increases, there will be baroreceptor activation, and there is a reflex vasodilatation, and the systemic vascular resistance decreases. So this is beneficial in a hypertensive heart failure, but it can be deadly if you have a patient with already a RV failure, pulmonary hypertension, or in a septic shock, or in an ARDS patient. They can kill patients. So here is the relationship between the alveolar volume and the pressure and the pulmonary vascular resistance, what I've just told. If you just if you forget all those intricate terminology and all these things, just remember that if you in a positive pressure ventilation, it gets like a squeezed and squashed the thin walled pulmonary vessels. So that would be your causing the decrease in the caliber of the pulmonary vessels, causing the pulmonary vascular resistance to go up. So again, so don't get frightened by this equation of motion of ventilation. So if you look at it, it's not that complicated. It's very simple. That's the airway pressure minus the muscle pressure, your pressure exerted by the muscle. So you can actually multiply by the surface area and get the force. So it is equal to your flow into resistance by volume into capacitance plus PEEP. So what happens if there is a auto PEEP? So the auto PEEP, there will be air trapping. So there will be alveolar over distension, and there will be air trapping, and there will be a sustained transpulmonary pressure. So when there is a sustained transpulmonary pressure, there will be very reduced like a right ventricular filling, and that can cause severe hemodynamic compromise. That is what you see whenever you put the patient on mechanical ventilation and try to save the patient. What happens? One is because of the effect of the drug and the hypoxia, hypercarbia is temporarily gone, the sympathetic discharge reduces. So the patient was having a lot of distress, lot of sympathetic activity. We have given some sedative, put the patient on mechanical ventilation, some amount of oxygenation done, some amount of CO2 has been washed out. So that is the sympathetic activation has now normalized. So that causes the next, what happens? Because of the increased transpulmonary pressure and increased transpleural pressure, so the right ventricular filling dramatically gets reduced. And also there is like a compression and the squishing and like a compression of the pulmonary vessels. So the right ventricular preload decreases, right ventricular afterload increases. So the right ventricular output falls. And if the right ventricular output falls, so where will the left ventricle get the blood preload? That is from the pulmonary vessels only. That is not happening. So that is why we see a reduction in the cardiac output and the reduction in the blood pressure whenever you put the patient on a ventilator. Be a normal patient, and it can be even lethal when and many a patient if you are not cautious enough to safeguard these things, you'll usually have a cardiac arrest soon after intubation ventilation in a patient with septic shock. So your so when does PEEP help and when does PEEP doesn't help? So as I told that if you have a left ventricular failure, so it would unload the left ventricle. How? Because a failing left ventricle which is overloaded. So by increasing PEEP, you can actually reduce the right ventricular preload and reduce the right ventricular output to the pulmonary circuit. So the overloaded left ventricle is now less overloaded, and its contractility would improve. It will again come to the steep part of the Flank-Starling curve. Again, there is an increased hydrostatic displacement of the alveolar edema, which will increase the oxygenation. Now, when it will be like a detrimental. So if you go on increasing PEEP and the right ventricular, the patient is already hypovolemic. The patient is already having dynamic hyperinflation. There is air trapping. So what will happen? It will reduce the right ventricular output so much. How? Because by the decreased preload of the right ventricle and increased afterload of the right ventricle, both. So that will reduce the cardiac output. So PEEP is not that keep all more the merrier. So you have to find, and every patient has their unique kind of a sweet point for PEEP. So we go for a individual PEEP titration, like a go in increment of 2 to 2, and if you see the hemodynamics are going bad and stagnant hypoxia is going up, means The BP is going down, cardiac output is going down, and you also have a oxygenation is going down. That is your worsening VQ mismatch. And if you see the PaCO2 EtCO2 gap goes wide, that means the dead space is going up. That means you have to reduce the PEEP. So nowadays most of the new ventilators, they have the volumetric apnea. So from there you can actually measure the physiologic dead space, and that's a like a vital piece of information where you can do the PEEP titration and what is the sweet point of your lung recruitment. So if you overdo it, it can actually be damaging the patient very much. So this thing I have already discussed. Now in a patients who have ARDS and who have a very reduced lung compliance, there is some good things that is happening, because you see in a normal lung or patient having other diseases, but the lung is compliant, so all the pressures would be very much transmitted to the as a juxtacardiac pressure. But in the ARDS, what happens? The lung can absorb a lot of a pressure because it is very less compliant. So what will happen? A patient with ARDS would tolerate much higher PEEP. But the same level of PEEP, if you give to a patient with a pulmonary hypertension, a patient who doesn't have an ARDS, patient has simple pneumonia, patient obtunded, that is why the patient is ventilated, intubated, ventilated, or simply under any surgery, you would actually doing serious harm to the patient. The cardiac output will go down. But in ARDS, the good thing is that because the lung is very stiff, it can absorb a lot of PEEP without actually transmitting the thing to the heart, to the pericardium. So what are the preload? So actually, this is the thing I have told. I am telling in a little bit different way. So so that those very detailed graph. This is a very difficult if we go in one go in a running lecture. So I'm going to tell it in a little bit in details. So whenever you put the patient on mechanical ventilation, you think about what are the preload effects of the mechanical ventilation on the RV function, what are the afterload effects, and what are the contractility effects of mechanical ventilation. Once you ask these three questions, you know what are the tweakings, what are the settings, what you are overdoing, what you are not doing. So you can reach the optimum point. So systemic venous return is passive. So there is no suction like a ventricular or atrium pump which can actually suck blood from the peripheries. No, it's a passive. So your positive interthoracic pressure raises the right atrial pressure. So there is a gradient reduces. So the RV preload reduces. It is very much evident as we have just discussed in so many ways. Hypovolemia amplifies this effect, like your septic shock, hemorrhagic shock, or your extracardiac obstructive shock. Like think about the patient on a thoracic surgery, for Ivan Lewis or your transthoracic esophagectomy or any kind of a thoracotomy for other things. So if you see the patient is already having a one lung ventilation. Now the surgeon to get traction, get exposure, they would just put a lung retractor and would just compress. They would just obliterate squeeze your right atrium. You will see the patient would simply become pulseless, and you have to just immediately, by a direct, unambiguous a communication to the surgeon. So, sir, please, would you please temporarily remove the retractor? The patient is getting pulseless. If you don't do it, you will be seriously harming the patient. You can even land up in cardiac arrest. So the thing you should be be able to correlate the physiology to the actual thing you see in the theater and in the ICU. In a tension pneumothorax, you should not wait for the ultrasound machine to boot up. If there's a tension pneumothorax and the patient is getting pulseless or just becoming obtunded and going into cardiac arrest, so bringing a ultrasound machine, confirming and all this, no. You have a risk factor that some intervention is done after a biopsy or something of that sort, and the patient dramatically got hemodynamically deteriorated. So you'll straight away go for your second intercostal space, like a puncture with a 14 or 16 gauge needle, because it will be rapidly fatal. So clinical. So if there is excessive PEEP on a preload dependent patient, it would cause a hypotension. So you can do a kind of a fluid loading. And before that, you can do a passive leg raise, PLR, by like get the remote control of the ICU bed or the OT table and then just like put it in the Trendelenburg position. So you can see whether it is a like a volume dependent or not. So there you have to reduce the PEEP. So here is your right atrial versus blood flow. This is not the Frank-Starling curve. So it is actually the right ventricular plus blood flow relationship. So if you see that it is similar to the Frank-Starling curve, but we have incorporated the intrathoracic pressure. So if you see as you increase the intrathoracic pressure, the same thing becomes much more shifted to the right and becomes the gradient. The gradient becomes it's not parallel curve. It is not parallel shifting. So it becomes like it starts to drop much earlier. If you have increased intrathoracic pressure, so you have this Frank-Starling relationship becomes modulated by the intrathoracic pressure. So you have a lesser increase of the cardiac output, even with the volume loading. Now we come to the afterload effects of mechanical ventilation. So the pulmonary venous return is a U-shaped curve, like suppose the low volume. So the different kind of a mechanism kicks in. There is atelectasis, there is hypoxic vasoconstriction. The pulmonary vascular resistance would go up. Again, at the functional residual capacity, there is an optimum thing. Things are very nice when the patient breathes at functional residual capacity, or you ventilate the patient at the FRC level. So there is hypoxia is not there, hypercarbia is not there. So the pulmonary vascular resistance is normal or nominal. Now you again try to achieve like a high. You give lot of PEEP. You give like ideal a table to maintain the normal carbon dioxide. So what happened? The pulmonary vessels will be squished and squashed, and the pulmonary vascular resistance would go up because of the capillary compression. So you see, if you are ventilating at very low tidal volume, atelectasis will be caused, hypoxic vasoconstriction will happen, PVR will go up. You go to near the FRC near about ventilation, things are fine. VQ matching is also good. You overdistend these things, you will worsen the RV afterload. So there lies what is the optimum driving pressure. So during surgery in the ICU, when the patient doesn't have like a severe ARDS, or one lung is completely destroyed or something of that sort, so we actually target around 14 centimeter driving pressure or less. So because that is a point of minimal pulmonary vascular resistance and adequate oxygenation. So now we come to the contractility and the RV myocardial perfusion effects. So if you have if you have a high intrathoracic pressure, so it can reduce the right ventricular coronary perfusion because the diastolic gradient, because although the RV gets blood both during systole and diastole, unlike your LV which gets only during diastole, RV being a low pressure system, it receives blood during systole as well as diastole. But because if you have very high airway pressure, it would be the gradient between the diastole and the aortic and the RV pressure would be reduced. So the right ventricular coronary perfusion pressure would be reduced with a high intrathoracic pressure because the diastolic gradient between the aorta and the RV pressure would be reduced. So we avoid high plateau pressure and a little bit of a permissive hypotension in RV failure. We don't try to achieve like what we called is the CO2 level should be the normal and all these things, and we don't overfill the RV, because if the RV is overfilled, again the transmural pressure would be high and the RV would get less filled, less perfused during diastole. So we are talking about RV although, but we also need to also talk about the LV a little bit. So I'll go in a very brief in a single slide. So RV, as I already told, LV preload depends on the RV output because it is in a series. Whatever the LV pushes out, the LV gets, RV pushes out, the left ventricle receives as a preload. So if the RV stroke volume gets reduced, LV will also gets reduced. And if the elevated intrathoracic pressure that reduce the LV after load, so it will actually help only in a hypertensive LV failure, not in other kind of a heart failure. Only in a hypertensive heart failure, the positive pressure ventilation works like magic, because it will reduce the right ventricular output and will unload the already overfilled left ventricle. So in a pulmonary edema and the left ventricular hypertensive failure. But remember, it has a flip side. So if you have observe very carefully, some patients, they have a deterioration after extubation, particularly those patients who had heart failure, or the patient after extubation, because of the sympathy reactivation, pain and all these things, they develop heart failure. So what is happening, this protective effect of the mechanical ventilation on the left ventricular function, which is already failing, it just vanishes as soon as you extubate the patient. More so, if you just put the patient on the T-piece, actually T-piece, putting the patient on a T-piece would actually be like a bringing in this kind of a like a pre-extubation T-piece pulmonary edema or the post-extubation pulmonary edema if the patient has a cardiomyopathy or a reduced left ventricular function. So the modern day practice is that you extubate the patient, you wean the patient on CPAP, you extubate the patient on CPAP and put the patient immediately on HFNC, because HFNC has been proven non-inferior to CPAP. So that's a goal. Rather than putting on the TP, just straight away, just like extubate and put the patient on nasal prong or oxygen mask when you know that the patient is already having a left ventricular failure. So this is calling for trouble. The patient will again get reintubated, and probably at this time the patient will have a cardiac arrest, hypoxia, hypercarbia, and ventricular arrhythmia, will die. So be very careful when you extubate a patient with heart failure, because this protective effect of positive pressure ventilation is gone. So now, as I've already told, this is the most important part which taught in MBBS, but nobody since told ki this is important. We don't recall and correlate with our practice, but everybody knows. So the alveolar oxygen tension, that is the PaO2, pH, and the PCO2 directly influence the pulmonary vascular resistance, as I told. And hypoxia, hypercarbia, acidosis, this is just a corollary of this of the above thing, and increases the pulmonary vascular resistance. So when the right heart is failing, don't do anything which causes hypoxia, hypercarbia, and acidosis. Like, as I told, like your patient is already having your like a right heart failure, RV failure because of a cor pulmonale or whatever. So you try to go for a AVEC intubation rather than subjecting the patient, like a patient is to sedate and paralyze. Now who is maintaining oxygenation? Who is maintaining ventilation? Nobody. The patient is, the spontaneous ventilation is abolished because of the like a poor lung compliance, or there is distended abdomen, the chest wall compliance is low, or the FRC is very low. The patient will, and you are unable to maintain oxygenation and ventilation by mass ventilation. So it is like a calling for trouble. All hell will break loose. So try to like go for a AVEC intubation if the patient is cooperative. So you avoid this hypoxia, hypercarbia, and acidosis when you are trying to intubate and ventilate a patient who is already having this RV failure. Or if the patient is non-cooperative or obtunded, you go for a rapid sequence airway. As soon as the patient loses consciousness, put a supraglottic airway, put an IGL, whatever you have, second generation. So you immediately gain control of the oxygenation and the ventilation. So the patient doesn't become hypoxic, hypercardiac, and the RV failure death spiral is not like starting. So what are the clinical implications? So it's complicated. So if you are if you go for a mild hyperventilation or buffering, it may transiently improve RV ejection, but while hypercarbia will increase the afterload. But if you are hyperventilating, trying to achieve a arbitrary like a CO2 goal, it will be self-limiting. Again, it will be reducing the pulmonary two things. Right ventricular preload will get reduced. Right ventricular afterload will get increased, because the increased ventilation would collapse the thin wall pulmonary vessels. Because you know the PVR is a U-shaped curve. Again, mild hypercarbia at your FRC functional residual capacity range of ventilation, you will have some amount of a sympathetic stimulation because of the mild hypercarbia, and you will increase the cardiac output, positive inotropy, positive chronotropy, and all these things. But if you are like a thinking, okay, it's good, let's do more, let's hypoventilate more, so the patient will again have a reduced like a right ventricular output. So high FiO2 reduces pulmonary vascular resistance, but if you have a high FiO2, it will absorption atelectasis again. So that will be like causing VQ mismatch. And in like a pulmonary hypertension, what we do, we give inhaled nitric oxide and prostacyclin. But remember, the danger is that if the patient is having a very severe like a left ventricular failure, along with this thing, the patient is going to die. Because why? If you are using a pulmonary vasodilator, it is going to vasodilate, and the left ventricle, which is a failing left ventricle, that is going to get overloaded. So we use these adjuncts, nitric oxide, prostacyclin, to counter severe pulmonary hypertension, provided conditions apply. Why? Where you have confirmed that the left ventricular contractility is more or less, is not like a very bad. It is like a at least around 40% ejection fraction, or whatever you see, like a left ventricular, like a velocity time integral, whatever you measure. So we'll rapidly go through the clinical scenarios where we like interpret and take decisions. So let's select the ARDS with right ventricular strain, severely hypoxic, severely hypercarbic. So, and we are like ventilating the lung at the top of our like a capacity of the ventilator. Increased pulmonary vascular resistance. Why? Because of hypoxia, because of hypercarbia, and because of the high distension pressure and the transpulmonary pressure. The pulmonary vessels are squished and squashed. So leading to the acute cor pulmonale. It is not just because of your ventilator settings, but because of the pathology also. So go for a protective strategy, PEEP titrated to the lowest driving pressure. Driving pressure, as you know, plateau pressure minus PEEP. And we go for pulmonary permissive hypercarbia only up to pH 7.2. Permissive hypercarbia, that is the limit. We cannot go beyond that. If there is acidosis more than that, it will itself cause RV failure. So again, the recap of this thing, as I already told, that the transpulmonary pressure is such an important thing. It is critical to keep the lung inflated, but if you overdo that thing, it is going to like a throttle and throttle the right ventricle. So in a difficult scenario, like a patient with a like a morbid obesity, like a edema, abdominal hypertension, like your abdominal compartment syndrome, your airway pressure is not going to reflect your pulmonary transpulmonary pressure. So in those situations, you have to put a esophageal balloon manometer to measure your transpleural pressure. So that will be the guide how you have to titrate the PEEP and all those things. Now the septic shock with RV dysfunction. So positive pressure ventilation will decrease preload, and your like and norepinephrine, we use the restore the perfusion gradient of the right ventricle. Otherwise, if the blood pressure drops so much, and so that the right ventricular perfusion pressure drops. On the other hand, you are squeezing the right ventricle, so it will happen. It will get ischemic, and it is not even getting enough blood. And with the positive pressure ventilation, you are increasing the afterload. So it is like a beaten up in all three fronts. So if you are like going for a very aggressive PEEP without even looking at what is the hemodynamics, what is the map, and so that is going to do harm. So in such situation, we'll go for your like a focus guided volume resuscitation. Fill up a underloaded right ventricle and don't overload a overloaded. How do we know? We can go for you can go for the IVC contract like a compressibility index. You can go for you can do a left parasternal short axis view, left parasternal long axis view. So look at the RV size in comparison to, you do not even need to do the exact measurement, just eyeballing. Normally 1/3. The RV is just a crescent shaped structure. The most superficial structure you see on the screen is your RV. So if it is a crescent shaped structure, almost roughly 1/3 of the LV. So anything like a more than that, it is almost like a half, more than 1/3, nearly half almost barabar, almost nearly the same size. It is something very wrong. The RV is overloaded. You don't further overload the RV. On the other hand, it is like a underloaded or just normal size. You can give in more fluids. And also you to have a poor man's cardiac output, you can, if you have a good view of your apical 4-chamber or even a 3-chamber view, you can actually measure the left ventricular outflow tract velocity time integral. It is very easy, but the thing is, that trick is that it will very, sometimes it becomes difficult to get that apical 4-chamber view. And you can do the venous access ultrasound. You look at the your liver, hepatic vein. If there's a the hepatic venous like a waveform, there is a pulsatile liver we call. So the patient is grossly overloaded and probably patient having a congestive hepatopathy in a severe RV failure. So we don't overload the patient with fluid. So in a LV failure, it is actually a boon. If the patient comes with a hypertensive heart failure, you always start with a CPAP or at least HFNC with at least like a 30 to 40 liters per minute flow. So that will give around 5 to 6 CPAP and would immediately your unload the right ventricle, which will in turn unload the left ventricle and will cause the failing left ventricle to perform better. As I told, weaning failure, if you just extubate a patient without paying into details, this thing that the left ventricular failure can get aggravated if you just pull out the tube and put the patient on oxygen mask. So you have to, by reducing the PEEP, you go for CPAP and see how the patient's contractility deteriorates, pulmonary edema deteriorates. Then you take a call for extubation, and after extubation, put the patient on HFNC. So the key point is that look at the driving pressure so that there is no atelectasis and causing weak mismatch. There is no over distension, which will call RV, preload to reduce, afterload to increase and cause RV failure. Maintain the lung volume near FRC. So that's the trick. So how you do it, it is unique for each patient. So that's the game, which the AI or probably algorithm can take over. The clinician has to do it. So maintain the MAP more than 65 to ensure RV coronary perfusion, and use a focus on mixed venous oxygen saturation as global surrogates of your oxygen like a flux delivery and your DO2 and VO2 balance. So by the transmural pressure and ventricular interdependence and the pulmonary vascular resistance. So whenever we are putting a patient on the ventilator or weaning and extubating, we always recall what is the effect, what are the afterload effects is going to happen, what are the preload effects, what are the preload effects is going to happen, what are the afterload are going to happen, what are the contractility effects are going to happen when we put the patient on the ventilator, or we just liberate the patient from the ventilator. And by where is the optimum balance for this particular patient. So there is a checklist which I follow. It's not like a very standardized thing. So we should have our own checklist where when we put a patient on a mechanical ventilation as a RV protective strategy. So we rule out hypovolemia. So don't just rush to intubate and ventilate a patient. You will kill a patient. You will have a cardiac arrest. And so you always first correct hypovolemia, put the patient on a little bit of a pressor if you need so. Keep the driving pressure low. Don't just chase arbitrary oxygenation and carbon dioxide target as soon as you start ventilating the patient. You achieve it, titrate the PEEP to the minimal driving pressure. I try to maintain the pH of around more than 7.30 and avoid marked hypercapnia. So you at times you may need to remove those what we call those catheter mounts to reduce the dead space, because hypercarbia will cause the increased pulmonary vascular resistance. We ensure the MAP, so that is why I would always prefer a little bit of a NORAD kicking in before you intubate and ventilate the patient in ICU, or you are inducing a patient who already has a pulmonary hypertension or a COPD patient with a chronic core pulmonary. So you just start it early rather than give it when things are already bad. So if the chest wall is stiff, as I told, is morbidly obese patient and abdominal compartment syndrome. So your airway pressure will not give you a good clue. So recently we had one such patients who had very high driving pressure and all these things, but that did not reflect the true pressure. Unfortunately, we did not do a esophageal balloon manometry, because that would require another, like a manometer, and we don't do it very often. So it was actually not done. So it should be done. So LV failure. So watch out for preload sensitive, like a RV. So, but at the same time, you avoid over distension. And weaning with cardiomyopathy, you anticipate LV failure during weaning, rather than like taken by surprise. If after extubation, patient suddenly breathless, diaphoretic, BP shoots up, and the patient is like having pulmonary edema and again getting reintubated and having a cardiac arrest during that intubation. So this is the thing I would want the last in my ICU. Anticipate increasing the LV afterload and RV preload when removing positive pressure ventilation. So you do a spontaneous breathing trial with echo and perfusion indices. So exam going students, these are the hot topics for the Viva. Most examiner, if they want to like grill you, these are the things they can actually ask, because these are very much connected to practice. So that's the thing. And these are my references, not for the sake of citing. So these are wonderful like articles, and I have not mentioned the mother of all the articles. It was published in 19. It was the study was done in 1948 and published in 1951, like that. The unfortunately, I just forgot the names of those great scientists. They did the study in like a 15 or 20 healthy human volunteers. The title was "The Effect of Pressured Breathing in Humans." So that was the like a seminal study which started this everything. So what is the effect of positive pressure ventilation on the cardiac function? So for and those they received the Nobel Prize for the recognition of their work. And still it is how many years? It's around like a more than like a 7 decades. Still we are like unveiling new things, and every time you see a patient, you find new interpretation when you see this heart lung interaction, particularly the mechanical ventilation and RV interaction. So thank you, and all the like outside like audiences who are from Kolkata and from other places, other outside like Varanasi. I would always like have a warm welcome whenever you come to Varanasi or somewhere here or Allahabad. You're most welcome to visit our institute. So we'd really appreciate that. Thank you. So I would like invite questions if there are any questions. Am I audible? Am I audible? If there are any questions, you can uh, post on the chat, or you can just ask by unmuting yourself.
Hello?
Yeah.
Am I audible?
Yeah.
Hello?
Uh-huh.
I have a question
Yeah.
that in endoscopic cardiac surgeries, we are used to do single lung ventilation in the
Mhm.
case of mitral valve stenosis with a pulmonary hypertension.
Right.
So we used to face always there is a decrease in the right ventricular function
Mhm.
during the coming off of the bypass and
Mhm.
around 4 to 5 hours after patient shifting, and
Mhm.
usually it normalizes the day after the OTs, but
Mhm.
that period is a bit stormy. So
Yeah.
how to prevent that?
You see, so again, we think of this airlines like a preload, afterload, and contractility. So mostly, we tend to underestimate the ischemic insult of the right ventricle during this phase. So mostly we are worried about the left ventricle, and we take extra balance to maintain the left ventricular perfusion and all these things. But what really happens in order to maintain the left ventricular performance, because the map depends on that, we direct all the therapies like your fluid, inotropes, everything just to maintain the left ventricular function. But what happens in doing so, the right ventricle suffers. How? So we are actually going mostly at times we overfill the right ventricle just to maintain the preload of the left ventricle. We use the map, and the patient in such patient mostly they will be on a mechanical ventilation. So these things, so if you can see, the right ventricle actually the perfusion pressure reduces because we are like a mostly overfilling to maintain an adequate preload in a failing heart. On the other hand, the diastolic the diastolic, the filling of the right ventricle in a already like a loaded right ventricle, so that is also going to cause the decreased contractility of the right ventricle. So there are no easy answers. So mostly what I am going to do, we can actually cannot eliminate this thing completely, but we can reduce. So how we can reduce? One is your we can go for your uh, go for much more precise loading targets rather than require arbitrary RV target. Because mostly we do not uh, measure the left ventricular outflow tract velocity time integral, because if you measure that and that is actually hovering around the normal of the patient, you do not need to go beyond, you do not need to overload and the right ventricle to achieve your arbitrary targets of your mean arterial pressure. Again, using PEEP. So we have our arbitrary oxygenation goal, because if there's it is like that, maintaining an oxygenation of around 70 millimeter of mercury PO2 is fine. We did not a target your 100 above and 130, or although that's a feel safe, but it is in doing so we are using a lot of PEEP, and also to protect the left ventricle we are also using a lot of PEEP. So that is actually that is actually harming the patient. So in short, what I can tell, there are no wonder drugs or single therapy which can actually like uh, 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 eliminate this situation. The clue is the PEEP titration and the fluid titration. You go by your your focus. Ultrasound guided, do a parallel parasol short axis or a long axis view, or if you get a apical four chamber view to get the left ventricular outflow tract velocity time integral, that is a surrogate marker of your left ventricular cardiac output. And a little bit less important, I would say, that's your tricuspid annulus, like a systolic excursion. That is so that if you can see, that measurement is also a guide how the right ventricle contractility is performing. Although that is not infallible, there are a lot of fallacies in that. Mostly the solution is that we have to find the spot where that particular patient has the maintaining the left ventricular output with the least RV loading. So that lies the clue, with the least PEEP. So there you will have a less like a stormy recovery. And also during the during the surgery itself. So how much ischemic insult is the right ventricle like a suffering? Any other thing? Any other thing you want to ask?
Just another query. Is there any rule of routine use of milrinone in such patients post-operatively 24 hours? Because some of the centers, they are using routine milrinone, but in some literature, it is not mentioned to be used in a routine basis for all the cases.
Yeah, so what we actually we don't have like a very strong scientific evidence like that it harms or it is beneficial, it reduces the ventilator state, improves the weaning and the overall like a hospital stay. But what my point is that if you have in a particular, it will not apply to all patients. In a particular subset of patient or cohort of patient, if you see, okay, the RV failure like is so much prevalent, so the patient usually will escalate. So if you have your local data like that, so it would be like a worthwhile. Like I would say in a similar situation, in if you've seen a lot of patients with septic shock, they will have which we see have a lot of like a septic cardiomyopathy, which was previously unrecognized. Even in the literature, it is grossly underreported. But the incidence of septic cardiomyopathy, where there is severe RV dysfunction, is quite frequent. Almost it reaches around 70%, 75% in our cohort of patients what we deal. So in those patients, as soon as we have a target map reach, we always add like a dobutamine. That helps a little bit. But if you tell, okay, is this the standard treatment? I would say no, because we don't have that evidence. But it would be, I would say, a very pragmatic decision. You actually you can do like a chart analysis, even do a study also. Like you can get it published. You just do a retrospective like a study. You look at the patient profile. What was the baseline like a baseline like a parameters, and what were their like how much their requirement of their anatropes and whoever used the milrinone and preemptively. So you will get the clue. Maybe in your cohort of patient that might be benefiting, but you're gonna apply like in all patients. So within your patient, maybe some of the patients pediatric patients are not requiring it, or some patients like your patient with some amount degree of COPD or some this disease this and that might be benefiting. So you have to look at your own data, and you will be actually be identifying the patients where actually preemptively you give a little bit of a inotropic support without increasing the your myocardial oxygen demand and causing too much of a tachycardia and all these things. That can actually be helping. Even we are using in certain unless there is like a severe like RV failure and severe LV failure, we are actually using your some ear dilator, that's your sacubitril valsartan, that patients are a little bit recovering, and we actually see the your cardiac contractility and also the biomarkers gets reduced quite dramatically. But I cannot claim it as a scientific evidence because we have not like done actually a study has not published it by peer review. So your local data, you have to look at the local data, how your patients are doing, and I'm sure you will be able to identify a subset of patients who are definitely benefiting from this treatment.
Thank you very much. And this is an excellent presentation and so much insightful for all of us. On behalf of Heartlines, we express our deep gratitude to Dr. Jyotirmay for sharing such a clear, practical, and a clinically relevant knowledge on mechanical ventilation and right heart function, which is actually so much neglected topic, I think. And your explanation actually truly helped us to see the physiology, ventilation strategies, and the right heart ventricular functions in a new light. To all our participants, thank you very much for joining us in this evening for your questions and your attention and your continued supports. Every session becomes meaningful because of this community have the motivated learners. So let us take these pulse of knowledge back to our ICUs and OTs and applying them in real situations. So wishing everyone a very peaceful evening, and we should look forward seeing all of you in our next Heartline session. Thank you very much. Thank you, Dada. Thank you very much.
Thank you. Thank you.